My name's Samir Mal, and I'm one of the fourth-year residents, and I was responsible for putting rounds together today with the tremendous help of Don Giffen. And we chose a bit of an offbeat topic. It's something that's hugely important to our practice, but I didn't really know anything about it, aside from I probably miss a bunch of them, is X-ray discrepancies in emergency medicine. There's actually a lot of literature out there on this topic that I didn't know existed previously. These are the objectives for the talk today. Firstly, we're going to start off and review our practice at LHSC with a couple of small reviews that have been done recently with respect to discrepancies, and we're going to try to identify any obvious areas where we as a physician group can improve. And we're also going to explore the idea of a feedback mechanism and if it's worth it for the emergency department, if it's worth it for our patients or our own practice. Next, we'll move on and review some of the literature on the accuracy of emerge physicians reading plain radiographs and if our misses are associated in general with any poor or adverse events with patients. I want to determine the types of errors, the error rate, that sort of thing. After that, I'll hand the floor over to Dr. Etemad, who I think most of you know from radiology. She's been a huge resource to the emerge and especially to our residency program, so we'd just like to thank her again for coming out today, and she'll take us through some interesting cases that have popped up. Lastly, if we have some time, I'll take you through some slides for the most frequently missed orthopedic injuries, but that's kind of on the back burner. So to start off, discrepant x-rays. They're a concern in every single emerge department across the country, and the biggest reason for this is the obvious potential for adverse events with patients. I mean, you can think of pneumonias getting sent home, coming back more sick, or getting avascular necrosis from missed, talar or scaphoid fractures. So there's a huge concern there over us missing findings. Now, I haven't been involved with the legal system much yet in Canada, but in the States anyway, I guess more so, there's no Canadian data available. Litigation is a huge concern. There's no published Canadian data, but in the US anyways, missed orthopedic injuries were the largest source of ER physician malpractice claims in the States, and the amount of money paid out to settle these claims was the second greatest out of all claim suits. So it's a huge deal in the States. Most emerge departments across the country have some sort of QA process already in place for departments to deal with discrepancy reports. Now, for those of you not familiar with the process at LHSC, I think most of you work here, but just in case, I'll quickly go through it. When an x-ray is done on a patient in the emerge here, it automatically is available on the online viewing system. In the emerge, since we're trying to get throughput as quickly as possible, we often look at that x-ray, and based on our own interpretation and combining that with history, physical exam, and lab findings, we either treat the patient or send them home. Now, the onus is on the physician looking at the film to put their interpretation up on the PACS machine. Depending on what time of day the x-ray was taken, the staff radiologist will eventually get to it. If it's during the daytime hours, that can be 15, 20 minutes. However, if it's later on in the day or after 5 p.m., that overread can often take another 24 hours. Once that overread is published, if there's any obvious differences between the official radiology report and the emerge physician report, that x-ray gets flagged and gets put into a special folder on the PACS monitor. And here in London, we've designated the 4 a.m. to 10 a.m. doc as the one who's responsible for looking through that folder every morning and dealing with the discrepancies as indicated. So, in general, studies have shown a discrepancy rate between ER physicians and radiologists of anywhere between 1 and 12%, depending on the type of x-ray that's being read and the study that you read. This can be as high as 45% with internal medicine house staff, and I'm not putting that stat up there to say medicine residents can't read x-rays, but what I'm saying is for a large majority of the day, 15, 16 hours, there are people in the hospital making important clinical decisions based on their own perceived ability to read an x-ray, which can have implications. In general, patient management tends to be altered in between 1 and 3% of cases, and these are people who need to return for some sort of immobilization, change their follow-up, get admitted to a service, or have their last final examination. In general, emerge docs are more comfortable with orthopedic injuries, and chest films are what give us the most trouble, and I'll go through that in a little bit more detail. So how are we doing at LHSC? Well, as part of this grand rounds, Don and I thought it'd be a good idea just to do a quick little, nothing extensive, small 2-week review of all the discrepancies at both Vic and UH. And we wanted to determine the nature of discrepancies, the time to acknowledging, and the time to reporting for both the eMERGE and radiology. We did a retrospective review just at the end of October, beginning of November. And the endpoints we were looking at were the mean time to radiology report, the proportion of films that had an eMERGE doc note, and we just informally wanted to look at patient outcomes as well, see if any badness happened. So, initial results. We had 76 discrepancies over the 2 weeks. One patient had a CT, they were excluded, so we ended up with 75 total. That works out to about 2 to 3 discrepancies per day per site. So I've only been here a few years and just started learning about discrepancies now, so I'm not sure if that seems like a lowish kind of number to me. Mean age was 50, just over half of them were male. Next slide, any guesses on what percentage had an eMERGE doc note attached to them? Resident staff, shout out a number. Anyone? 100, 50? 25, oh God. Anyone else? 61%, so we did a little bit better than Dr. Dreyer said. So, 61%, no man, we suck. I don't know how else to say that, man. The times are at the bottom. That graph shows the mean time in hours from the ED report to the official radiology report. So that mean time was approximately 10 hours in our cases. And from the radiology report to the eMERGE acknowledging the report, so calling the patient back or whatever, that time was 23 hours on average. Now, other interesting results, all the discrepancies thankfully had proper follow-up, all 75 patients. In total, 20% of the patients were admitted. 3 of those patients had to return for their admission. The 3 that returned are right there. There was a young guy with a wedge compression fracture who was called back and came back in with some foot pain as well and ended up having a concomitant calcaneus fracture. So he was admitted. There was another young zygoma fracture that came in for an overnight procedure, and a lady with interstitial pulmonary edema who came back and was admitted to CTU for a couple days. But overall, there were no adverse events associated with our misses. So in summary, kind of interesting findings from this little review. Collectively, we need to increase our practice of reporting x-rays. I mean, 61% that's pretty horrid. And the other, I think, interesting finding that came out of this was we need to figure out a creative way in which to decrease our response time once a discrepancy is posted. Like I said, our mean was 23 hours, and a couple of the cases that I just mentioned of patients coming back, they waited 23 and 46 hours respectively for their discrepancy report. So no data on response times in other studies, so I can't say if our 23 hours, where that stands versus some industry standard, but that's what it is. So a couple years ago, a more extensive review, I don't know if you guys remember Carol, she was an EM resident, I believe in 2009. Her, Marcia, and Shelley put together an excellent project that was presented at CAPE as well, where they looked at x-rays over a 2-week period just in the Vic eMERGE, and they looked at all x-rays. Retrospective study once again, and they wanted to check the total number of discrepant reports, the mean time to dictation, and the compliance in dealing with discrepancies. So this was a breakdown of the x-rays that they found in their study. As you can see, chest and all ortho x-rays combined made up the significant majority of x-rays that we read, and chest x-rays almost make up the same amount as all orthopedic x-rays combined, and they also tend to be our worst for interpretation as well. This was their graph. Initially 1,192 plain film reports. They ended up with 347 clinically significant discrepancies. 68% of those clinically significant discrepancies did not have a radiology, did not have a eMERGE doc report associated with the x-ray, so those were automatically flagged. And 6.1 of those were a true discrepancy, so 21 out of the 347. With respect to the times that they found, we actually improved a little bit. They found their time from the discrepancy getting posted to the eMERGE doc acknowledging the note was about 30 hours, so we've improved a little bit in a couple years. And it seems like their time from x-ray to radiology report or emerge physician report was about the same in our study, just over 15 hours. So right now it seems like we're doing a little bit better than we were before. So now, possibility for feedback. This is what I'm going to explore next. Now, like I said before, discrepant x-rays, they're flagged by the radiologist and placed into that specific PACS folder. Once they're acknowledged by the emerge doc, that film is deleted out of that folder and it's sent into the big abyss of all x-rays that have ever been done. And currently, which was very, very surprising to me, there is absolutely no way to retrospectively select or search for discrepant x-rays. You either have to know the patient PIN or name, or you're kind of stuck. I called 5 different departments in the hospital because I thought someone out there must have a list of all the discrepancies, but nowhere to be found. So due to this fact alone, ongoing clinical education is made very difficult. And we're, as it stands right now, just relying on the doc who acknowledges the discrepancy to send us a note if there was an interesting finding or not. And I guess the question that comes from this is it worth the effort to institute more formal mechanisms for dealing with our discrepancies? Will it change any behavior, or are we good enough just to keep the status quo and let's just not create more work? So to help look at this, there was a study done in 2000 and published in the BMJ called Reducing Errors Made by EPs in Interpreting Radiographs. This was a great study, longitudinal, which looked to reduce errors made in the interpretation of radiographs in the emerge department. And it was a longitudinal study in a U.S. academic emerge department. They excluded all CTs, MRIs, ultrasounds. It was just plain radiographs they were looking at. And they measured baseline error rates for 12 months and then had 2 different interventions occurring at a year apart. And then they measured error rates after each of those interventions and saw if there were any changes. The method that they had at this hospital set up to read films was during the day. Much like here, the radiologist would report directly to the emergency physician. In between 5 p.m. and 10 p.m., the radiology resident would report directly to the emerge physician. And 10 p.m. to 8 a.m., the emerge docs were relying on their own reading. So this is how it was at the beginning of the study. So first intervention came 12 months later. And this intervention was as follows. The radiology and emerge department started collecting clinically significant radiographs, and they were mandatory for review at all monthly meetings. A teaching file was created, and it was mandatory for all new hires to go through the entire teaching file and go through the discrepant x-rays. There was a second intervention a year later where they put a more They put together better communication methods between radiology and emerge, and also increased the hours that staff radiologists would be available. So the second intervention had radiologists 7 days a week providing overreads within 12 hours of the film being taken. And as well, a discrepancy form was created. So this was back in the 90s before everything was electronic, but a discrepancy form was created and given directly to the emerge doc by the radiologist to look over the discrepancy. So that was their second intervention. And here are their findings, which were really, really interesting, I thought. Their false negative rate, so the rate of misses, was at the beginning of the study 3%, which is about the higher end of normal depending on what you read. And after their first intervention, they were able to drop the false negative rate to 1.2%. That further fell to 0.3% after their second intervention. And you can see there at the bottom that change seemed to be pretty consistent over time. The error rates for radiograph interpretation for emerge docs, the adverse events fell to a few cases per 1,000, which is pretty great. And it really showed that rather than just comparing 2 specialties, it shows the improvement that we can make in patient care with collaboration. And it's kind of obvious to say it like that, but thankfully we have something to back it up. So how are we in general at interpreting radiographs? And this is beyond LHSC. So this was a review actually just published earlier this year in the American Journal of Emergency Medicine called The Accuracy of Radiographic Readings in the Emerge Department. And the purpose of this study was to review all ED discrepancy interpretations and review types of error. This was a huge retrospective database covering 9 years. They looked at over 150,000 x-rays. This was in an academic urban level 1 trauma center at a center with a residency training program in emergency medicine. And all discrepancies were classified as either bone, chest, or abdomen. Once again, they excluded all CTs, MRIs, and ultrasounds. It was just plain radiographs they were looking at. And in this review, it was actually the third-year eMERGE residents, at this center anyway, who are responsible for dealing with the discrepancies. So the resident would either classify the discrepancy as a false negative or a false positive or neither, if there was no note put up by the initial reading doc. And after the chart review, the resident would be responsible for either taking no action, calling the patient, changing follow-up, bringing them back to be admitted to the eMERGE department. So here's their flow chart. They initially started off in those 9 years. They had a total of 5,660 discrepancies. After excluding some people, they ended up with 4,605 total that they included in their analysis. Just over half of all those discrepancies were chest films, 42% bone and 5% abdominal. Right there at the bottom of the chart, you can see that the majority of our errors were false negatives as opposed to false positives, so undercalling things as opposed to overcalling. Right here. So if we start looking at each modality individually, with respect to orthopedic films, acute fractures and soft tissue lesions made up the biggest amount of misses. And if we break down the fractures even more, it was fingers, ribs, and toes where we seem to have the most trouble identifying fractures, which I guess is also the fractures that we would care about the least as well. If we look at chest x-rays, all things considered, if we look at chest x-rays, by far the majority of the misses were pulmonary, and this was airspace disease. Airspace disease specifically accounted for 770 cases out of the 2,200 chest x-rays, and there were 300 pulmonary nodules in there, so I guess we need to improve our pulmonary nodule pickup rate. These two tables here, table 6 is all discrepancies across all radiographs, and really all to say there is fractures and pulmonary disease were the most common areas of misses in general. Table 7 on the right-hand side, this was a summary of the 109 patients who were discharged and subsequently had to come back to the eMERGE. Out of the 109, 5 of those returned via EMS. There were a couple misses of free air, mediastinum, and bowel obstruction. So a couple of those patients had to come back emergently. But all in all, they had absolutely no adverse events in those 9 years associated with the physician misses. So to date, this has been the largest database review of X-ray discrepancies. And having the gold standard as the official radiologist report, eMERGE physicians had a discrepant interpretation rate of 2.9% of all cases, which is pretty good. We infrequently missed clinically significant findings, and only in 0.05% of cases would the radiology reading have emergently changed our management in the eMERGE department. So back to our own discrepancy list now. So like I said, ongoing clinical education is extremely difficult simply because of the fact we don't collect or keep a standard record of all discrepancies. We rely on a very informal method of feedback, and often we don't get it. And due to all this, there's no ongoing clinical education for the staff, for the residents, or for the med students. Now, you can probably make the argument that the status quo was all right. I mean, from this couple small reviews that have been done anyways at LHSC, it seems like our error rates are probably in the high end of normal. We haven't really had any bad adverse events happen from our misses. Patients are all receiving proper follow-up, so why create more work? Let's just keep it as is. And I mean, I said you can make an argument that way. I didn't say it'd be a strong one. And I think most people in this room would agree there are certain areas that we could definitely change our practice with respect to discrepancies. So this is just a couple suggestions for improvement. And the first 2 points I put up there as possible suggestions, but I mean, let's be honest, I can't see either of these actually panning out. I mean, we'd have to, idea number 1 would have someone keep a manual log, whether that be a resident or a physician. I don't know how reliable that would be, paper or electronic, and then someone would be responsible for writing and updating it daily. I don't know about that. Secondly, we could mandate that all eMERGE docs have to notify the initial reporting physician with a discrepancy, but I mean, now that's asking a lot too when someone's worked a night shift and going through 10 discrepancies and now has to send 10 different emails to people. So I mean, even though those are suggestions, they're not really. And I think the best thing to do would be have some sort of, I'm not great with computers, but there must be a way to have an automatic message generated somewhere in the PACS or IT system that could be delivered directly to the initial reporting physician. One small fact that complicates things is the PACS monitor. I don't know if all of you are aware, you log in and it doesn't have the same timeout that FirstNet and PowerChart do. So quite often, the same person's PACS account will be open all day long, and everyone in the department will just be will be using their account. So often, if notes are posted, if people remember, they're posted under another physician's name. So if we were to just rely on the name that was up on the PACS monitor, we may not be sending the discrepancies back to the appropriate physician. So staff ideas, I don't know, this is something hopefully we'll have some time to discuss at the end of the presentation, but it'd be great to hear what people think we can, how people think we can change. Now, specifically another area of improvement that I think we can make is within our own interpretation of chest radiographs. They account for a significant proportion of our scan volume, and they're also considered to be one of the most complex imaging modalities to interpret in the first place. Many studies have demonstrated a significant discordance between emerged physician reports on chest x-rays and official radiology reports. In our own review that Dawn and I did, 41% of our discrepancies were from chest x-rays. And in the AGEM article that I presented a few minutes ago, discrepancies were twice as likely in the chest x-ray category than in the orthopedic x-ray category. So this was also studied by, an article was published in 2003 in the BMJ looking at specifically emerged physicians' ability to read plain chest radiographs. And emerged physicians were compared to senior radiologists in this study. This was a prospective cohort. I believe this one was done in Israel at an academic center. So they took 507 consecutive patients who were discharged from the emerge after having a chest x-ray. And those patients were prospectively followed to see what happened. They'd be followed until the official radiology report was up, and they also looked at the types of discrepancies and how patients were being followed up. All these patients' files were reviewed on a daily basis as well by one of their research assistants. So their main outcome measures was the absolute volume of missed findings and the impact on patient care at the end of the day. So this is the diagnoses that people left with after receiving a chest radiograph in this study. By far, the most common were nonspecific. 45% of patients left with some nonspecific diagnosis. You can see the rest of the list there. In total, there were 557 abnormal findings described in the 507 x-rays by emerged physicians, and in the end there were 647 errors identified, 647 abnormal findings identified by radiology within those same studies. So here are the sensitivities and specificities broken down for each of the following findings that emerged physicians had. So overall, you can see the sensitivities were pretty low. Our sensitivities tended to be best for consolidations and congestion. Our sensitivities were also best when they broke the findings down into high clinical significance versus low clinical significance. So we were good, we were sensitive, relatively, 60 or 70%, when there was a highly clinically significant discrepancy present. Our specificities are over there on the right-hand side of the table, and you can see our specificities were best for pleural effusions of all things, but we otherwise didn't do too badly in that regard. So their summary of their results were, despite the low sensitivities found, there were really no clinical implications. Patients were all receiving proper follow-up within an appropriate amount of time, and they didn't have any adverse events. The misses tended to be of either a very minor nature or they were appropriately followed up in a very timely fashion. So their conclusions of this study were that there is significant discordance between emerged physicians and senior radiologists reading chest x-rays, and they said emerged physicians need to improve our knowledge of reading films. But at the end of the day, all that being said, I do agree with that statement, but once again, no adverse patient events happened in this study as well. It's food for thought. So, practice guidelines published by the American College of Radiology. These were put out in 2008 with respect to the type of coverage that radiologists are striving to perform anyway in the States. So this is not a requirement of practice, or it's not a standard of care. This is just a consensus statement from the College of Radiology regarding their services. So radiologists provide comprehensive imaging services to patients seen in the eMERGE and provide timely consultative services for a patient's physician. They broke down the word timely a little further on in their paper, and timely said, timely interpretation of imaging examinations by qualified radiologists performed on eMERGE patients will facilitate decision-making regarding their treatment and possible admission. Now, I don't even know if bullet number 2 is possible here with the volume of studies that we do and the amount of the staff that we have. I'm not really sure if we can expect bullet number 2 24 hours a day. And I guess the other question for the group is, do we need it 24 hours a day? Do we as a group feel we're, as I said before, good enough the way it is? So to conclude the first part of my presentation, I hope I've at least identified some specific areas in which we can improve our discrepancy practice. Specifically, that's in creating our own reports, which is not being done enough at all. We can respond more quickly to discrepancies. Again, I don't have comparison data, but our average was about 23 hours. And lastly, we can explore the idea of feedback mechanisms, and hopefully that one study I presented showed that error rates can be changed if we care to take that next step. In general, eMERGE physicians are fairly proficient at reading X-rays. There's almost no cases of adverse events related with our misses, and chest X-rays seem to be a particular challenge. So that's the summary of the first half of my presentation. Now I'm going to hand the floor over to Roya, who's going to take us through some interesting X-rays that have come up recently.
When Dawn sent me a list of discrepancies that we're collecting over a 2-week period, there were maybe 30, 40 cases, and I went through them, and a lot of them are not really important discrepancies. There was maybe something very minor that was not commented on, and I know you guys are very busy and you usually just write nil acute or fracture or pneumonia or something like that, and I'm sure a lot of times things are seen, you just don't have time to write it down. So what I did was I went back and as Samir said, there's no way we can actually look for discrepancies to say, I want the discrepancies that were sent by Dr. X between this time and that time. That would be something that I'm actually working with the PACS people to see if we would be able to actually retrospectively collect these cases. I was looking for cases that would actually be important, would have an educational value, not just, oh, you just missed this little bone island. And I came across a couple of images. If you have time, we're going to go through, I don't know how you want to do this. I can just show them and give you a minute to have a look at them. These are cases that were seen in emergency department, and usually the eMERGE physician's note is negative, nil acute, or something like that. The first one is a 62-year-old female, comes in with the question, rule out obstruction. She had 3 views of the abdomen. The one thing that's really important, you can change the window. So don't look at images the way they're presented to you. You can always make them darker or brighter. So as you can see, it's a larger body habitus, and just going to give you a minute. So whenever the error is upwards, the patient is upwards, so they're standing, and the 3 views are usually the supine, the upright, and the chest X-ray. So error is downwards. This is a supine image. And larger patients, because they're not going to fit on one film, you're going to have more than 3 views. You might have 5 or 6. It's just the same supine or erect that you're taking from different parts of the abdomen, basically just to fit the abdomen on one view. So this is another supine, error is downwards. And that's the right side of the abdomen. And there's a chest X-ray. So this came back as nil acute. What do you think? Free air, perfect. Okay, so again, change the window. Free air, if air is free, it's going to rise up to the diaphragm. So the left side, the left upper quadrant is always tricky because you're going to have bowel over there anyways. But free air usually looks different from bowel gas. So if you have air in your stomach, it's usually in a rounded, lobulated pattern. it's usually not a crescent like that. Free air comes up to whatever surface there is and it stops. So free air usually takes a linear or crescent shape. So even if there was a question about the left side, the right side, this is free air. But even if you didn't have that, if you look at here, this is an upright, this is free air. Okay, so even if you didn't have the chest x-ray, that's free air. The supines, obviously, we're not going to see free air on a supine, but if you have an upright, just look up there. And again, not all free airs, you don't necessarily have to look for free air. Sometimes we have extraluminal air. So if you have a rectal tumor that's perforated, for example, or diverticulitis, you can actually have air escaping from the colon, but it's not free. It's not going to rise up. So you're going to have sort of a bubbly appearance of the air that's extraluminal air, but not free. So this was free air, and this patient actually went on to have a CT the next day, or the same day, I guess. So it's much easier to see the free air on CT. And there we go. These are all bubbles of free air. It's actually quite a lot. And this patient, this is all air. This patient actually perforated their colon. Again, it's a large patient. It's difficult to see small bubbles of air in large body habitus patients. So one tool that you have at your disposition is the window. So don't look at it at whatever window it's given to you. Change the window, it makes it easier. Next one is a 2 views of the chest, young person. See these every day. I'm going to give you the frontal and the lateral. So there's the frontal. And there's the lateral. Look at this mediastinum. This is too wide. These hyla are too full. The heart is too prominent. There's a trace of pleural effusion. That's really small. The lungs themselves are pretty much clean. There's really nothing in the lung. And when you look at the lateral, there's a trachea coming down. This is the region of the mediastinum. This is too full. There's too much density here. It's sort of a lobulated area of increased density, which would actually correspond to what you see on the frontal view. So this would raise the possibility, again, this is not a trauma patient. If this was trauma, wide, dense mediastinum, you would think, aortic injury, any kind of vascular injury, dissection, anything like that. And a young person who comes in unwell, maybe night sweats, losing weight or something like that, do have to think about malignancy. We don't see them very often, but have to keep it at the back of your mind. This person had a CT. Again, this was called, I think, right lower lobe pneumonia or something like that. So they actually, because a malignancy was suspected, we did a CT chest abdo-pelvis. Again, we usually don't do head-to-toe CT in a young person because of the risk of radiation, but there was enough suspicion on the chest x-ray to want to have a full CT. So right off the bat, we're starting from the top. There's the aorta. This is all adenopathy. This is why the mediastinum is so wide. These are all nodes. That's all nodes. So he did have adenopathy. This was actually a lymphoma, and even worse than that, let me show you the bones in this person. And this is something, even going back, we didn't really see the abnormality in the bones as much. See the lytic lesions? The bone is completely eroded, and it's not just one focus, multiple foci. The bone is very abnormal. So this was a lymphoma that came in as a pneumonia. And again, just going back to the chest x-ray, the telltale signs are just fullness in the mediastinum and in the hyla. This is something to look for. And also the lateral. The lateral is really useful. I know a lot of people are afraid of looking at the lateral because they don't know what to look for. So always look at the mediastinum. If it's too full, there is usually, you should only have vessels there, nothing else, okay? So if it's too full, think about adenopathy. This one is a 57-year-old male who comes in with chest pain. 2 views of the chest. So frontal and lateral. And the emerge note said, question mark, left upper lobe infiltrate. Anybody wants to take a guess? Again, chest pain is really non-specific, could be anything. I think the trick to this one is, again, to change the window. If I change the window, all of a sudden things stand out. See this nodule here? And there's another one here. Okay, and on the lateral, there's this linear density. If you look at it, it's linear, it's projecting over the heart, it's quite dense, and this is a coronary artery stent. It's quite a long one, actually. So this patient is a vasculopath. They do have coronary artery disease. And the other thing is that look at the sternum. The sternum is pretty flat, so it's not completely a pectus deformity, but it's a very flat sternum. So what happens, especially in a thin person, when you have a pectus or a flat sternum, it pushes the heart back, and it usually displaces it to the left, and it makes the vessels in the right hilum stand out. So a lot of people in a pectus patient, they call right middle lobe pneumonia, because they're just, the vessels are prominent, they're more patchy looking. All it is just the sternum pushing the heart over. So there's no pneumonia here, but there's something nodular there and another one there. And when you see someone like that, especially in a 57-year-old, you want to look in the upper abdomen, because you always get the upper abdomen for free. Look for the spleen, see if it's big. Look at the hyla, see if there's any adenopathy, and look at the bones, just like the last patient. So a lot of times when we have a malignancy, they might have metastatic disease already, and you might actually see something in the ribs or the clavicles or the shoulders. So again, this patient had a CT. So the bases were okay. So that's the first nodule you saw. There's another little one here, and that's the third part. So these are more airspace nodules. They're not real rounded, well-defined nodules. This patient actually had an infection. This was not a neoplasm. They had bronchial thickening, and they had a repeat chest x-ray and showed that they resolved. So sometimes the pneumonia doesn't show as a lobar pneumonia. It's not always patchy. It can actually show up as something nodular. And again, the trick, I think, to this case was just to change the window and bring out the nodules. Because otherwise, if you just look at it on the normal window that you get, you might miss them. This one is a trauma case. This was a 29-year-old male. I don't know what the trauma was, but we got this chest x-ray, and actually the question was question mark laceration versus contusion. So overall, when you have a quick look, it doesn't look too bad. We're looking for major trauma, so pneumothoraces, hemothoraces, rib fracture. The trachea is pretty much midline. So at first glance, young person doesn't really look too bad, and this was called normal. If you look down here, again, I don't know if it projects well or not, there's an air fluid level. So there's the diaphragm, and there's a cavity. There's an air density. It's really subtle. And if you look back here, again, there's an air fluid level. It's really subtle. But as I always tell the residents, if you're looking on a lateral chest x-ray, as you come down the spine, the vertebral bodies should get darker, not wider. This is white. Okay, so there's something sitting here in the right cardiophrenic angle. Now, this is an area where we have a lot of pericardial fat pad, for example. You can get hernias coming up there. We don't have any previous, unfortunately, in this patient to see if he has had anything before or not. But we did some follow-up on him. So this was October 28th, and then he came on November the 15th to look at the same place. And as you can see, it looks much better. It's still there, but not as prominent anymore. So we didn't have a CT, which is too bad, because it's always nice to have the CT to confirm what you're thinking. The thought was that this is probably a laceration of the lung. It's caused a pneumatocele, and it's bled into it. So the air fluid level is air blood level. And over time, over a month's time, it has healed itself. So there was no pneumothorax, there was no hemothorax, but this was a very small pneumatocele caused by the traumatic injury. And I don't think it was followed, but nothing was done about it, and it got better. So really subtle. And the other thing to think about is maybe hernias. You can have Bactelac hernias or Morgagni hernias in this region. The problem is that if you don't have a previous imaging, you don't know how long this has been there. So we're assuming that's what it is. We don't have a CT to confirm that. Very subtle. This one is a female patient, 43-year-old female who comes with epigastric pain. Again, 3 visits of the abdomen. There's a chest x-ray. So epigastric region, again, looking in the epigastric region to see if there's any free air, any fullness, how big is the spleen, is the gastric bubble pushed one way or another, how is the spine looking, any organomegaly. This is one view of the abdomen. Arrow is upward, so this is an upward, erect. And arrow downward, so this is a supine. Just give me a minute. So again, this was, there was no note actually, there was no emerge note. So sometimes a discrepancy is sent. If we see something and there is no note, we don't know if this was seen or not. So some of the discrepancies you might receive is something that gives you the report. We just don't know if this was seen or not because there was no note. So in this case, there was no note. So there was nothing wrong with the epigastric region. The bowel gas pattern was okay. The finding was the SI joints. This is a 43-year-old woman. If you look at the SI joints, they're fused and they're very sclerotic. So this is bilateral sacroiliitis, something that was probably a very surprising finding. And when this was sent to emergency, they actually asked her, and she had a CT for this particular purpose, and she was being treated for sacroiliitis. The reason why she came to emerge was not that. They already, she was treated in another hospital, actually. She was not from London. So this was just an incidental finding. Again, if you don't look for it, you're not going to see it. This is something we always look for in Crohn's patients. If you have a young patient and they already have sacroiliitis, we look for that if inflammatory bowel disease is something that you're worried about. So even if you have abdominal films, you still have to look at the bones because a lot of times you have incidental findings. You also pick up a lot of metastases, bony metastases. Again, the trick is to change the window. Don't look at it on the same window. This is a 19-year-old male who was involved in a trauma, and he has foot views and ankle views. I show you the ankle views. So we always have 3 views of the ankle. And again, what's important is change the window and look at soft tissues. I find soft tissue swelling really important because we never get to see the patient. You actually examine the patient. You know which side is hurting, which side is swollen. So right off the bat, he's 19, so his physes are fused, but you can still see the physeal line. But he's definitely swollen. Even in very obese patients, the ankle usually is an area where you would see the swelling, even if they're usually not thin. The ankle is one of those areas you would, especially if it's an asymmetrical swelling. So he's definitely swollen over the lateral malleolus. If you look at here, this is not really a fracture. If I show you the enlarged image, that's just his physis, okay? So we're thinking, why is he swollen? And don't forget, a lot of times they get ligamentous injury that we're not going to see. So it's really important to look at the joint space, make sure that the ankle mortise is preserved, medial malleolus, lateral malleolus, and the lateral. Again, don't forget the lateral. The lateral is really important. So he does have a joint effusion, okay? And again, I don't know how well this is projecting. If you look down here, there's a fracture. Again, let's just change the window and bring it out. Okay, there's the fracture line. You're not going to see that on the frontal or the oblique. The other thing was that he had foot views the same day. And there's a fracture. Again, just because you have the foot doesn't mean that you shouldn't look high up here. And a lot of times you actually find the fracture on a different x-ray. So this was called negative, and this was a fibular fracture. Again, look at the soft tissue swelling. That's really important. I don't know if you want to have a discussion or questions and answers. These were just a couple of cases that I pulled some of the discrepancies that were actual discrepancies.